Hello, students. My name is Heidi Haldeman. I'm one of the professors at Aspen University, and we're here to talk about cultural competence, Chapter 2, as part of Module 1 of Health Assessment. One second here. Cultural competence. So what are the questions we're going to ask? So who are you meeting for the first time? Where does the patient come from? Where were they born? What is his or her heritage? What is his or her cultural background, meaning their ethnicity and their religion? Do they understand, speak, and read English? What language does he or she understand, speak, and read? And what are his or her health and illness belief practices? So today we're going to talk about the demographic profile of the United States, national standards for culturally and linguistically appropriate services, background of a heritage assessment, the methods for conducting a heritage assessment, traditional health and illness beliefs and practices, and steps to cultural competence. So health and wellness. What is health? Health. The balance of a person is a complex interrelated phenomenon, right? We're not just our physical health, but we're our mental health, our spiritual health. In the outside world, we have natural, communal, and metaphysical. And what is illness? So an illness is a loss of a person's balance. So that could be physical balance, mental balance, or spiritual balance. And in the outside world, natural, communal, or a metaphysical imbalance. So the demographic profile of the United States. So the total population passed 311 million in 2011. Greater than 1/3 of U.S. residents were other than a non-Hispanic white. So the minority or emerging majority population total 114.5 million people. The largest, fastest growing group is Hispanics. Second largest population is the Blacks, and then Asian American Indians, Alaska Natives, Native Hawaiians, and other Pacific Islanders make up the third largest part of the population. Differences noted in age, poverty level, and household composition are some of the minority group trends. So it tends to be as follows: younger with lower median age, higher proportions under 18 years old, meaning a ton of kids. All ethnic and racial minority groups exceed the national poverty level, and family size and multi-generational families are more evident in the minority group. So where you have, multiple families living together, especially, and very close-knit families, but large families, meaning, they have a lot of children compared to other groups. Status of immigrants entering the healthcare system. So sometimes you have legal permanent residents. You might have a naturalized citizen, undocumented aliens, refugees, legal non-immigrant residents. I mean, we hear about this all the time on the news, right? Many new immigrants have only a minimal understanding of how we deliver health care, of our nursing practices, medical practices, and our interventions, and they don't even understand English. So imagine not feeling well, being sick, and going somewhere and people don't even understand what you're saying, how frustrating that could be. So it's imperative that our care be tailored to what we perceive their needs are, even if they can't, tell us. So national cultural and linguistic standards. So the first and landmark standard is healthcare organizations should ensure that patients receive from all staff members effective, understandable, respectable care that is provided in a manner compatible with their cultural health beliefs and practices in preferred language. Not ours, theirs. And that's from the National Standards for Culturally and Linguistically Appropriate Services in Healthcare, a final report from Washington, D.C., Office of Minority Health. Department of Health and Human Services. So what does that mean? We need to give effective care, which means positive outcomes and a satisfied patient. We need to be respectful of their values, their preferences, and their needs. We need to be competent, so with congruent behaviors, attitudes, and policies that come together in a system that enables cross-cultural situations and good, sensitive, knowledgeable care. Title VI of Civil Rights Act of 1964, services cannot be denied to people with limited English proficiency. So in 2012, over 21% of Americans over 5 years of age spoke a language other than English in their home. Most commonly, it's Spanish. Patients who have limited English proficiency, that's actually a thing, LEP, are at risk for poor health outcomes. If you can imagine you weren't a nurse and you didn't have any health knowledge and you went to a country where they didn't speak your language and they gave you instructions. You can imagine that you might not be compliant with those instructions because you might not understand them. So of course they're going to be at risk for poor healthcare outcomes due to a language barrier of not being able to understand what we're trying to tell them. So, how do we give culturally sensitive care? We need to possess the knowledge and the attitude towards the cultural populations. That means that you go in with your kind, caring attitude of how to take care of this patient. You don't go in rolling your eyes, annoyed, they can't understand me, how can I get them to understand me? So, that is not culturally sensitive. Culturally sensitive is seeking to understand, seeking to make them comfortable, seeking to be more knowledgeable about their culture. So, culturally appropriate is having the knowledge necessary to give the best care. So, sensitive means, have the knowledge and have the correct attitude. Culturally appropriate means you need to have the background knowledge necessary to provide the best care. And then culturally competent is where we're attending to the total context of a patient's situation. So we need to know their immigration status, their stress, their social factors, their culture similarities, and what the differences are, and be respectful of those. So how do we do this? We need to understand our own heritage-based values, beliefs, attitudes, and practices. You need to identify the meaning of health to the patient. What you consider healthy, what I consider healthy, someone else might not consider healthy. For example, certain cultures think it's best to be thin. Other cultures see their children overweight and think that's a sign of good health. And you might think, what? That's not a sign of good health. But they might look at another child that's thin and think, oh my gosh, that child's not healthy. Okay, so that's just an example that's just one thing, and there's a gazillion of them. So understand how healthcare systems work, acquire knowledge about the social background of their patient, become familiar with their language, their interpretive services, meaning, what are the services so that you can actually have a conversation with them and there's an interpreter or a translator, and then community services that are available for them. What must the nurse possess? What must the nurse assess first when providing culturally competent health care to an Asian American patient? Number one, the tradition of the Asian American culture and the health care practices related to health and wellness. Number two, the nurse's heritage-based culture values, beliefs, attitudes, and preferences. Three, any differences between the nurse's culture and the Asian American culture. 4, the attitude of Asian American culture healthcare system in the U.S. So what is it? Number 2, the nurse first needs to be able to determine what biases or differences exist prior to rendering care to any other culture. Answers 1, 3, and 4 are all good, but you must begin with, your own beliefs to understand someone else's. So what are related things that we need to talk about here? So the 4 basic concepts of culture are learned, shared, adapted, and dynamic. So race and ethnicity, so for self-identification in the social group. The acculturation, assimilation is one-dimensional, and the biculturalism integration is bidimensional. Acculturative stress, and so what are some losses and changes associated with integration of new beliefs? And then religion and spirituality, organized system of beliefs versus your individual experience. Culture. What's the definition? It's the thoughts, communications, actions, beliefs, values, and institutions of racial, ethnic, religious, or social groups. And so there's all sorts of characteristics of cultures. There's learned culture, shared, adaptive, or dynamic. What's ethnicity? This describes a group united by a common area, geographically, migratory status, religion, race, language, shared values, traditions, and symbols, and even food preferences. Religion is a belief in a divine or superhuman power or powers to be obeyed or worshipped. This is a system of beliefs, practices, and ethical values, and it can be a shared experience of spirituality. Socialization is the process of being raised within a culture and acquiring characteristics of that group. So the related terms to socialization is acculturation, and that's where you adapt to and you acquire another culture. This happens all the time. You go into a new job and it's another culture of that job, because culture is just how things work there. How are things done? Your child goes to a different school. There's an acculturation process. And so this has to do, this can be within a culture, this can be within a group. Socialization happens all the time. When you become a nurse, there will be socialization into being a nurse. There's a socialization into being a nursing student. So this is a very common thing that occurs. Assimilation is where you actually develop a new cultural identity and become like a member of the dominant culture. When you're a nurse, you're going to be assimilated into that field. They're talking about race and culture and ethnicity here, but it really applies to a lot of things, just to help you understand. And then biculturalism is where you have a dual pattern of identification where your loyalty is divided. Health-related beliefs and practices. So there are all sorts of different beliefs and practices based on someone's culture and their ethnicity, about causes of illness, about science, whether it's natural or holistic care, with the yin and yang and hot and cold, different religious perspectives, and then traditional beliefs versus health healers. Biomedical, where they're looking at what's the cause and effect. Some view the body as a machine, life can be divided into parts, and it endorses the germ theory. So that's like your biomedical. The naturalist thinks that a force of nature must be kept in balance, and it embraces the idea of opposing categories or forces like yin and yang and hot and cold. The religious, where they look at supernatural powers, are predominant in the area of health and illness. So there could be voodoo or witchcraft or faith healing. These things exist. Healing and culture. In addition to seeking help from healthcare providers, patient can also seek help from a folk or religious healers. And, Hispanics or American Indians may believe, it's incomplete unless the healing is carried out in your body, your mind, and your spirit. Health-related behaviors affected by religion. So these are just some of the things that can be affected by religion. Meditating, that's a spiritual practice. Exercising or physical fitness, how you sleep, whether or not you get vaccinations, the willingness to undergo a physical exam, because maybe you're not allowed. Pilgrimage, truthfulness about how a patient feels. So they look like they're in terrible pain, and they're stoic, and they will not admit they have pain. That's an example of that. Maintenance of family viability, hoping for recovery, coping with stress, genetic screening and counseling, living with a disability, and caring for children. So all these things can be affected by somebody's culture. And you can have like a different view of epilepsy. So Uganda, they believe it's contagious and you can't treat it. In Greece, it's a source of family shame. The Mexican American community believes that epilepsy means there's a physical imbalance. And then Heurides means you've endured a trial by God. The developmental competence. So there's beliefs and values that are across the lifestyle with dominant cultural beliefs. So there's folk healers, which you can see all the different lists of different folk healers by culture. Culture affects choices parents make for their children, looking at what causes their illness, the treatments that they try, the acceptability of treatments offered by clinicians. For older patients, culture is likely to define their family responsibility and affect their view and knowledge of health systems from their dominant culture. Pain is huge, how they express pain. So their expectations, their manifestations, their management of pain can be very cultural. Pain has been found to be a highly personal experience depending on the culture, learning the meaning of the situation, and other factors unique to the person. Because what if your culture thought that if you did something wrong, then you would have pain? You're not going to act like you have pain. I mean, I could go on all the different cultural situations where you can see that somebody has pain and they tell you they don't have pain because something within their culture is going to make it very difficult for them if they admit to having pain. Silent suffering has been identified as the most valued response to pain by healthcare professionals. A condition that is culturally defined. So, culture bound syndromes. Some have no equivalent in a biomedical scientific perspective. Anorexia nervosa and bulimia are examples of cultural aspects of illness in dominant culture population in North America. So, that's really just a North America thing. Steps to cultural competency. How do we get there? So, to be culturally sensitive, we need to possess knowledge and understanding. To be culturally appropriate, we need to apply the knowledge to improve health outcomes. To be cultural competent, you need to have a concept of understanding of the contextual aspects of care. And then cultural care is where we provide health care across the cultural boundaries in the consideration of their culture. Cultural formation models. So the categories, there's the cultural identity of the individual. Then you explain the individual's illness. There's different factors related to the psychosocial environment and the level of functioning. Cultural elements of the relationship between the individual and the clinician, and then the impact of culture on diagnosis and care. Because your care, you can't tell them to go do something that you know they're not going to do based on their culture. And so every single step, whether it's the assessment that you need to assess a patient with somebody else in the room, or to know that they're not going to make eye contact, or to know that they're not going to tell you what their pain level is. So that's the assessment part. And then there's the treatment part. Will they accept treatment? And then when you go to evaluate, how do you know whether things are working or not? And so there's so many different culture affects every single step of the nursing process. So culture accepts every single step of the nursing process. Heritage consistency. So this is a degree to a person's lifestyle reflects his or her traditional heritage, because some people don't want to associate with their heritage, and other people do. So living within the norms of your traditional culture, and then are you acculturated to the norms of the dominant